Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, which is a premier virtual clinical pharmacy institute for capacity building for healthcare workers. It is the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time as I share with you some tips which may prove very, very handy in your line of duty. So I welcome you all to part 99 of our MCQ pharmacotherapy series, Measuring in Infectious Diseases. Welcome. The first question reads, Mrs. JST, a 66-year-old female patient, was admitted to your medical ICU due to a massive pulmonary embolism, PE. She requires ventilatory support. 7 days after admission, your clinical team diagnosed Mrs. JST with septic shock secondary to ventilator-associated pneumonia, abbreviated as VAP. They empirically initiated her on linezolid at a dose of 600 mg IV twice daily and piperacillin tazobactam at a dose of 4.5 grams infused over 4 hours every 6 hours, and ciprofloxacin administered at a dose of 400 mg infused over 1 hour twice daily. Today, the endotracheal aspirate culture report shows Pseudomonas aeruginosa, which is sensitive to all anti-pseudomonal options. Her chemistry is within normal limits. The WBC is 119.5 and the procalcitonin is 25 nanograms per ml. Some of the vitals include an MAP of 63 on norepinephrine at a dose of 10 mics per hour with a heart rate of 100, and the body temperature is 99.6 degrees Fahrenheit. So my question to you is, which of the options listed below would be the next best course of action in Mrs. JST's case? Would you maintain the current regimen to complete a 7-day course? Would you choose to discontinue ciprofloxacin? Would you discontinue piperacillin tazobactam and linezolid and continue with ciprofloxacin alone? Or would you opt to discontinue linezolid? I'll give you 10 seconds to choose the correct answer. I would comfortably discontinue linezolid. D is the correct answer. It's the most appropriate because the anti-MRSA is discontinued and the two anti-pseudomonal agents are maintained. That is Cipro and Piptaz. Now, the IDSA guidelines recommend the use of two anti-pseudomonal agents that the organism is known to be susceptible to if the patient remains in septic shock and or has a high risk for death, like this case. Now, JST will require, or rather still requires norepinephrine. Therefore, there is need to maintain two anti-pseudomonal agents. Now, the anti-MRSA agent is no longer required based on the culture results which we've just received. I would like to add that the IDSA guidelines recommend the use of non-invasive sampling with semi-quantitative cultures, e.g. endotracheal aspiration or similar methods over invasive sampling such as BAL, bronchoalveolar lavage, with quantitative cultures. Now, trials haven't been able to prove that clinical outcomes are improved by more invasive sampling, so avoid them. Avoid exposing the patient to unnecessary risks. I would just like to add that in VAP patients, where the causative agent is Pseudomonas aeruginosa, without a high risk of mortality or septic shock, the selection of the agent based on susceptibility panel is recommended. Just like to add that aminoglycosides poorly penetrate the lungs and have higher risks of adverse effects, and studies have shown inferior clinical responses when they are used compared to alternative therapies. Now, in VAP caused by Pseudomonas, with higher risks for mortality and or septic shock, two anti-Pseudomonas agents that the organism is known to be susceptible to should be used. I'm underlining that again. I'm intentionally repeating myself because of the importance of the matter. And discontinuation of one of these agents should be done once septic shock resolves, not before it resolves. I would just like to emphasize that a growing level of evidence has shown that the use of piperacillin tazobactam plus vancomycin has a high likelihood of causing acute kidney injury compared to, for example, using beta-lactam therapies in combination with vancomycin. So just remember that. Use piptaz with vanco very cautiously. Let's move to the next question, please. And the next question reads, Mrs. TJO, a 57-year-old female patient, presents to your accident and emergency department with community-acquired pneumonia, abbreviated as CAP. The emergency medicine consultant calculates her CAB65 and PSI scores to gauge Mrs. TJO's severity of illness. Mrs. TJO's CAB65 score is 1 and she is PSI class 2. So my question to you is, which of the levels of care listed below would best suit Mrs. TJO's clinical scenario? Would it be appropriate to admit her directly to the medical ICU, or would you choose to admit her to the general internal medicine ward, or would you simply triage Mrs. TJO and discharge her with the appropriate antibiotic regimen, or would you admit Mrs. TJO to a 23-hour observational stay unit? I'll give you 10 seconds to choose the correct answer. I would opt to triage this lady and discharge her with the appropriate antibiotic regimen. Now, patients with a PSI of class 1 or 2 should be treated as outpatients, and those with the CAB65 score of 0 to 1 should also be treated as outpatients. So those two facts make me biased towards triaging and discharging home with the appropriate antibiotic regimen. Let's move to the next question, please. And the next question reads, one of your infectious diseases team members is administering cytoven, which is ganciclovir to a patient for the treatment of cytomegalovirus infection, CMV infection. My question to you is, which of the side effects listed below would be the most important to monitor for, especially if this patient is HIV infected and is on azidovodine-based regimen? Would it be pulmonary fibrosis, worsening of pulmonary function tests? Would it be severe painful peripheral neuropathy? Would it be bone marrow suppression, that is neutropenia and thrombocytopenia? Or would it be renal failure with a rise in serum creatinine? I'll give you 10 seconds to choose the correct answer. C would be the best answer. Bone marrow suppression with neutropenia and thrombocytopenia. Just like to start by reminding you that bone marrow suppression is one of the most significant side effects of ganciclovir. This is the reason it is reserved for only the very severe infections. And the main use of ganciclovir is CMV treatment, and that is because of the higher resistance of CMV to aciclovir. Aciclovir would not work. And just like to add that renal failure or toxicity is more associated with aciclovir, not with ganciclovir. So that's just a by the way. Let's move to the next question, please. And the next question reads, JTM is admitted to your general medical ward and culture results have grown Pseudomonas aeruginosa. So my question to you is, which of the cephalosporins listed below would be the treatment option of choice for Mr. JTM, assuming the bacteria isn't an MDR strain? Would you opt to administer cefixime, marketed as Suprax? Would you settle for cefalexin, marketed as Keflex? Or would you choose ceftazidime, marketed as Fortaz or Fortam? Or would you choose to infuse ceftriaxone, marketed as Rocephin? I'll give you 10 seconds to choose the correct answer. I would settle for ceftazidime, Fortam or Fortaz. Now, from the above list, only ceftazidime has coverage for Pseudomonas aeruginosa infection, the gram-negative bacterium. Now, I would like to comment that cefalexin is a first-generation cephalosporin with predominantly gram-positive coverage, not gram-negative coverage. So don't use it in this scenario. Cefixime and ceftriaxone are both third-generation cephalosporins, just like ceftazidime, but they do not cover Pseudomonas aeruginosa. Just like to remind you that ceftazidime or ceftazidime avibactam, marketed as Avicas, and even cefepime and ceftolozane tazobactam, marketed as Zebaxa, are all cephalosporin antibiotics that have coverage for Pseudomonas aeruginosa. I'll repeat the drugs again. Ceftazidime avibactam, that is Avicas, cefepime, ceftolozane tazobactam, Zebaxa. Yeah, all those can be used in cases of infection with Pseudomonas aeruginosa as the pathogen. Let's move to the next slide, please. And the question reads, Mr. TBT, a 54-year-old male patient, has been stable on dolutegravir, co-administered with the emtricitabine co-formulated with TDF for a decade. Recently, the infectious disease consultant at your hospital who is managing his case diagnosed him with the case of hepatitis C infection, HCV infection. He will be treated with ledipasvir co-administered with sofosbuvir as a fixed dose combination called Havoni. Now, as the HIV pharmacist at the ID clinic, you run a drug-drug interaction checker and you notice that ledipasvir may increase the serum concentrations of TDF. So my question to you is, which of the options listed below would be your recommendation to the ID team or to the ID physician or to the HIV specialist regarding this drug-drug interaction? Would you alert him or advise him to completely change the regimen, then start HCV treatment right away? Or is it true that the patient can be monitored for TDF-associated adverse events while treatment continues? Or is it true that the TDF component of this regimen could be switched to TAF? Or is it true that the DTG, dolutegravir component should be switched to raltegravir? I'll give you 10 seconds to choose the correct answer. So both answers B and C are correct. I would just like to comment that TDF can be switched to TAF since TAF has fewer bone and kidney toxicities, and the DTG component has no drug interactions with the ledipasvir, so it doesn't need to be changed at all. Now, while you could completely change the ART regimen to a regimen that doesn't interact with the ledipasvir, so sofosbuvir, you would want to first check the HIV RNA levels within 2 to 8 weeks after changing the HIV therapy to confirm the effectiveness of the new regimen. Now, several antiretroviral drugs and HCV drugs have the potential for clinically significant PK drug-drug interactions when used in combination, so be very, very cautious. Just like to remind you that before starting HCV therapy, the ART regimen may need to be modified to reduce drug-drug interactions. That's a general principle. Now, after ART modification, because of the hepatitis that you must inevitably treat, the initiation of an HCV drug regimen should be delayed for 2 weeks or more. Now, the prolonged half-life of some of the HIV and HCV drugs poses a potential risk for drug-drug interactions if a regimen is resumed too soon after modifying an ART regimen or after completion of the HCV treatment. So be very, very cautious when you are transiting, when you are introducing the HCV treatment to a patient who has already been on ART. Let's move to the next question, please. And it reads, Mrs. PZO, a 56-year-old female patient, develops candidemia due to Candida glabrata during her current admission at your hospital. The sensitivity data for this candidemia is still pending. Currently, as an outpatient, she has been taking hydrochlorothiazide and sertraline. So my question to you is, which of the empiric options listed below would be the most appropriate for Mrs. PZO's clinical scenario now? Would you opt to infuse liposomal amphotericin B over 4 hours? Would you choose to administer fluconazole IV over an hour? Would you choose to administer anidulafungin, or would you settle for voriconazole? I'll give you 10 seconds to choose the correct answer. I would settle for anidulafungin and echinocandin. Now, the IDSA guidelines recommend echinocandins as the preferred option for empiric treatment of candidemia due to Candida glabrata. Now, patients already receiving an azole antifungal who are clinically improving can continue on the azole antifungal. Just like to add that step-down therapy to an azole antifungal is also acceptable once susceptibility data is available, and it points to susceptibility to azole antifungals. Remember that. It's a good antimicrobial stewardship strategy. Let's move to the next question, please. And it reads, which of the side effects listed below is associated with the use or administration of fluoroquinolones? Is it kidney stone formation, nephrolithiasis? Is it hemolysis, that is the destruction of the red blood cells? Is it increased risks of seizures? Or is it fractures of the foot? I'll give you 10 seconds to choose the correct answer. So increased seizures or increased risk of seizures would be the best option there. Now, I'd like to remind you that the only listed side effect associated with the use of fluoroquinolones from that list of 4 is seizures. Now, fluoroquinolones can increase the risk of seizures by lowering the seizure threshold. That is, they allow the neurons to fire more rapidly. Now, by modulating the function or activities of the GABA receptor, this happens, especially in the presence of NSAID medication. Now, anything that inhibits the activity or function of the GABA can decrease its inhibition on the neuron, making it more excitable. Fluoroquinolones can cause tendon rupture, not foot fractures, so that makes D wrong. They can also cause prolongation of the QT interval. So that is another risk, especially when you infuse the fluoroquinolones too fast. Endeavor to infuse them over 60 to 90 minutes, depending on the dose, to avoid prolonging the QT interval. Let's move to the next question, please. And it reads, Mr. RKN, a 27-year-old male, is diagnosed with syphilis. He doesn't recall how long he has been symptomatic, and he has no known drug or food allergies. He has no significant past medical history. So my question to you is, which of the therapeutic options listed below would suit Mr. RKN the most? Would you opt to infuse penicillin V? Would you opt to infuse penicillin G? Would you opt to administer penicillin G benzathine intramuscularly? Or would you settle for penicillin G procaine and administer it IM? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for IM penicillin G benzathine. Now, the CDC 2010 Sexually Transmitted Diseases Guidelines recommend the use of benzathine formulation once weekly for 3 weeks, or for 3 doses, 1 dose per week for late latent syphilis, as well as syphilis of unknown duration. Remember, this patient is uncertain. Then I'd just like to remind you that penicillin G IV is recommended for patients with neurosyphilis. And the procaine formulation is an alternative in patients with neurosyphilis. Then I would just like to add that penicillin V only exists as an oral formulation. So A is totally wrong. There is no penicillin V IV formulation in the market. Let's move to the next question, please. The next question reads, Mrs. JIT, a 38-year-old female patient, presents to your accident and emergency department with a case of community-acquired pneumonia. She presented with a flu 2 weeks ago, and 5 of her staff mates have been absent from duty with flu for the last 7 days. She last traveled out of the country 2 years ago. So my question to you is, which of the pathogens listed below would be the most likely cause of Madam JIT's pneumonia? Would it be Pseudomonas aeruginosa, Legionella pneumophila, Streptococcus pneumonia, or Francisella tularensis? I'll give you 10 seconds to choose the correct answer. So Streptococcus pneumonia would be the correct answer now. I'd just like to start by saying that Staph aureus and Strep pneumo are more common in the community. They are rampant in the community. They typically occur after primary viral infections, which is the reason why Staph aureus, for example, is classically associated with secondary bacterial pneumonias. Now, just like to add that Legionella pneumophila is more common in people who have had hotel or cruise ship stays in the previous 2 weeks. And then Pseudomonas aeruginosa is common in patients with structural lung disease. There is no mention of that in this particular case. Then Francisella tularensis is responsible for tularemia. It is more common in patients exposed to rabbits or soil where rabbits have been killed. Now, people whose career is landscaping are also at a great risk of tularemia. Now, we've not been told this guy is a landscaper either. So Staph aureus and Strep pneumo are the major causative agents of such cases of pneumonia. So C would be the correct answer in this particular case. Let's move to the next question. And it reads, Mr. JPM, a 33-year-old male patient, presents to your clinic with a chief complaint of fever lasting 2 weeks and a sore throat which failed to respond to antibiotics. He has been sexually active with several male sexual partners within the last 30 days and he didn't use a condom during intercourse. Some of the pertinent labs include HIV antigen/antibody screen, which is positive. His HIV RNA is 800,000 copies per ml. So my question to you is, which of the therapeutic plans listed below would be the most appropriate for Mr. JPM now? Should he start therapy right away with dolutegravir, abacavir, and lamivudine? Or should he start therapy right away with dolutegravir and lamivudine? Or can he start therapy with bictegravir, tenofovir, alafenamide, and emtricitabine? Or is it true that he shouldn't start therapy until his throat infection resolves? I'll give you 10 seconds to choose the correct answer. C is the correct option. This person can start therapy with bictegravir, tenofovir, alafenamide, and emtricitabine. Now, ART is recommended for all people with HIV to reduce morbidity and mortality, and also to prevent the transmission of HIV to other people. Now, the best regimen here is bictegravir, TAF, and FTC, since it doesn't require further testing. And this patient meets the criteria for using this regimen. Now, the panel of antiretroviral guidelines for adults and adolescents recommends initiating ART immediately or as soon as possible after HIV diagnosis. That is mainly to increase the uptake of ART and linkage to care. And it also reduces the time to viral suppression for individual patients, and it improves the rate of virologic suppression amongst people living with HIV. Just like to add that DTG and lamivudine could be an acceptable regimen to start only if the patient had an HIV RNA below 500,000 copies per ml. So it doesn't suit this particular gentleman who has around 800,000, if I remember well. Then I would like to add that DTG, ABC, and 3TC would require that an HLA B*5701 screening is done first to determine if the patient would be hypersensitive to abacavir component of that regimen. Now, the abacavir hypersensitivity reaction is multi-organ clinical syndrome, typically seen within the initial 6 weeks of ABC treatment. Now, recommended initial regimens should follow the most recent DHHS guidelines and should be individualized based on the clinical scenario you are dealing with. Let's move to the next question, please. And it reads, Mr. ABT, a 44-year-old male patient who has been living with HIV for the past 20 years, is being switched to a new regimen consisting of tenofovir, alafenamide, emtricitabine, and a boosted darunavir, which is co-formulated with cobicistat. Currently, he takes 81 milligrams of aspirin once a day, 80 milligrams of lovastatin at night, and 75 milligrams of venlafaxine. As the clinical pharmacist specialist at the HIV clinic, you run a drug interaction checker. So my question to you is, which drug-drug interaction should you alert the treating physician about? Would it be lovastatin interacts with Mr. ABT's new regimen, and therefore the physician should switch the patient to simvastatin at a dose of 20 milligrams at night? Or is it true that lovastatin interacts with Mr. ABT's new regimen, therefore he should switch to pravastatin at a dose of 40 milligrams at night? Or is it true that lovastatin interacts with Mr. ABT's new regimen, therefore he should switch to atorvastatin at a dose of 40 milligrams at night? Or is it true that lovastatin interacts with the regimen, therefore it's okay to take the regimen as long as ABT separates it by at least 12 hours apart? I'll give you 10 seconds to choose the correct answer. Lovastatin interacts with ABT's new regimen, therefore it should be switched to pravastatin at a dose of 40 milligrams at night. Now, I'd just like to remind you that lovastatin is a substrate of CYP3A4. Darunavir and cobicistat are strong CYP3A4 inhibitors. Therefore, they would lead to very high serum lovastatin levels. And that makes lovastatin contraindicated with darunavir co-formulated with cobicistat due to the potential for serious reactions, which may include myopathy and even rhabdomyolysis in extreme cases. Just like to emphasize that pravastatin doesn't have severe drug-drug interactions with the darunavir and cobicistat, since it isn't a CYP3A4 substrate at all. Now, simvastatin is also contraindicated with darunavir and cobicistat, since it is also a CYP3A4 substrate. And I would like to comment that atorvastatin isn't contraindicated with darunavir cobicistat, but it doesn't have a dose limitation. Sorry, it does. Sorry for that slip. It does have a dose limitation not to exceed 20 milligrams at night, since myopathy is still possible in this cohort of patients. Now, separating lovastatin from Mr. ABT's HIV regimen by 12 hours will not eliminate the drug-drug interactions at all. And typically, this advice is given with PPIs. I would just also like to add that co-administration of the HMG reductase inhibitors, the statins, which are pharmacokinetic enhancers with PIs poses a risk of myopathy and even rhabdomyolysis and acute renal failure. So avoid using them together. I would just like to remind you and repeat myself that lovastatin and simvastatin are contraindicated. Underline the word contraindicated with darunavir and cobicistat at any dose. Don't co-administer them. Pravastatin should still be initiated at the lowest dose possible and should be monitored for safety. Don't just introduce it and let the patient continue taking without monitoring. There would be a danger, there would be a risk there. Let's move to the next question, please. And it reads, Mr. FPJ, a 16-year-old male, was recently diagnosed with meningitis. Parents of this boy's classmates are now calling your accident and emergency, requesting for prophylactic antibiotics for their children and for their entire families, their entire households. So my question to you is, which of the following would be the most appropriate response to the concerns of these parents who keep calling your A&E? Could you tell them that too much time has elapsed and everyone should report to the A&E for meningitis workup immediately? Or would you tell them that for only those who came into contact with bodily fluids is prophylaxis necessary and they should order rifampicin at a dose of 600 milligrams twice daily for a day? Or would you reassure them that chemoprophylaxis isn't indicated at all? Or would you order azithromycin 500 milligrams, start doses for everyone? I'll give you 10 seconds to choose the correct answer. I would reassure these concerned parents that chemoprophylaxis isn't indicated. I'd like to start by commenting that chemoprophylaxis is only indicated in highly selected scenarios. Now, for cases where Neisseria meningitidis has been isolated as the causative pathogen, close contacts of the patient should receive chemoprophylaxis. And if those individuals have come into contact with oropharyngeal secretions, either through kissing or sharing of toys or beverages or cigarettes, then it would be important to do chemoprophylaxis. And you could administer rifampicin at a dose of 600 milligrams twice daily, orally for 2 days. And for kids, you do 10 milligrams per kilo per dose. Now, you can also use azithromycin at a dose of 500 milligrams as a start dose. You could also use ceftriaxone at a dose of 250 milligrams IM as a start dose, or even 500 milligrams of ciprofloxacin orally as a start dose. Now, for cases of Haemophilus influenza, chemoprophylaxis can be implemented for all close contacts in households with unvaccinated or immunocompromised children, with rifampicin at a dose of 600 milligrams daily for 4 days. Now, I would like to add that given the high incidence of fluoroquinolone resistance, ciprofloxacin can be used for chemoprophylaxis after a culture and sensitivity has demonstrated that the pathogen is susceptible to ciprofloxacin. I would just like to remind you that rifampicin is a CYP inducer, and its use as chemoprophylaxis or as a chemoprophylactic agent should be only in highly selected patients, because it could interact with other medications that they may be taking. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video, which is part 99 of our Pharmacotherapy MCQ series. If this video benefited you in any way, I would like to humbly urge you to remember to give it a thumbs up, to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I'd also like to urge you to leave your comment at the bottom of the video. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video, which will be part 100 of our Pharmacotherapy MCQ series. Thank you very much.